Hey everyone, welcome back to another episode of the Easy Conversations podcast, a podcast about having easy conversations. I'm your host, Furkan Dandia. In this week's episode, I'm excited to welcome back Dr. Lena Haji, who was also on an episode earlier in the season, which I recommend you check out. But she's a licensed clinical psychologist and mental health counselor specializing in psychodiagnostic assessment, forensic assessment, dual diagnosis, severe and persistent mental illness, depression, anxiety, personality disorders, and substance abuse treatment. Her clinical experience over the last 20 years includes working with mentally ill and dually diagnosed adults in inpatient and outpatient settings, including correctional facilities, substance abuse rehabilitation centers, outpatient clinics, psychiatric hospitals, and private practice in 4 states, including New York, New Jersey, California, and Florida. Her ultimate goal as a psychologist, regardless of population, is to accurately diagnose and identify patient strengths and areas for growth to individualize treatment needs and goals. She was trained at the master's and doctoral levels in assessing and treating individuals ranging from mild psychiatric symptoms to those with severe and persistent mental illness, dually diagnosed patients, personality disordered patients, and psychopathy. In this episode, we talk about the challenges with diagnosing disorders because of the comorbidity overlap between various disorders and why practitioners must exercise caution when working with clients. We also touch on some of the challenges with mental health work due to the lack of funding and attention, and how people in lower economic situations are impacted the most and do not have the means to seek help. Please check out Dr. Haji's page on Instagram and her website. Her Instagram is at rise_psychological_services, and her website is risepsychological.com. And if at the end of the episode, if you could leave a 5-star review, I would truly appreciate it. All right, Lena, welcome back to the Easy Conversations podcast. Always a pleasure talking to you. I always learn a lot when we do talk, and I feel like this is a great, I guess, almost a sequel to our previous episode. But yeah, excited to have you here. I know we've done one episode before where you did introduce yourself, but I just want to give you an opportunity again to talk a little bit about what it is that you do and where you're based, just for listeners that may have not heard the first episode.
Yeah, absolutely. And as usual, thanks for having me. I think you're a great interviewer, and it's always an honor when I'm asked to, be on a podcast or anything. So my name is Dr. Lena Haji, and I am a licensed clinical psychologist in the state of Florida. I practice mostly forensic psychology. So that's really applying clinical knowledge to a legal question, a lot of court evaluations. I worked in prisons at the bachelor's level, at the master's level, at the doctoral level, on and off for 20 years. And yeah, that's pretty much it. Here I am, ready to answer and talk about mental health all day. Plus, it's World Mental Health Day, so that's pretty awesome.
Yes. I do see irony, though. We need one day a year for it, right?
See irony too. And there was like Mental Suicide Prevention Month, and it's like, shouldn't we be focused on suicide prevention all the time? I don't really subscribe to these days, but I did happen to see that, so yay us.
Yeah, exactly. Yeah, it's a good start. Let's put it that way.
It's a good start.
Yeah. So I guess focus of the conversation, and just to give listeners a bit of a flavor, what inspired me to reach out to you again was my own kind of schooling. Just did a recent course on psychopathology and realized that I don't know a lot, and also realized that, our first episode we covered misdiagnosis, but then there's this huge issue around not being able to diagnose properly, or a lot of the overlap within the disorders and the comorbidities within. The specific one that I came across was BPD and anxiety and depression, often because, a lot of these disorders fall on a spectrum, and people not being able to properly gauge what the symptoms are and what would, be something a person would be experiencing in terms of borderline personality disorder. I'll throw it over to you, share your thoughts, and then we can kind of go back and forth on that.
So yeah, I think the first most important piece to put out there is that diagnosis is obviously just one piece of the puzzle. And actually diagnosis per the DSM-5 TR was really, the reason diagnosis exists was really for professionals to talk to each other. So it was really for, your primary care doctor to have a way to conceptualize a cluster of symptoms over to the psychiatrist, over to the therapist, over to the case manager, right? So when you look at a diagnosis, people often say, well, diagnoses are judgments or they're labels or they put people in a box. And it's like, yes, but that doesn't mean it captures the entire individual. It's just a way for other medical and mental health professionals to communicate something rapidly. So I've never met two people with borderline personality disorder who present exactly the same, or bipolar or schizophrenia. So I think that's one piece that's important to clear up, that diagnosis is just one piece of the puzzle. That being said, I find misdiagnosis to be really rampant among every level, master's level clinicians, doctoral level psychiatrists. I find it's really pretty bad, in my opinion. And so I think that's because people don't take the time to read the DSM-5 or the ICD, whichever one you're using, they're very similar, and to really focus on the diagnostic criteria, especially with a disorder like borderline personality disorder, which, like you mentioned, has so much comorbidity. Of course, anxiety is a part of BPD. Of course, depression is a part of BPD. So then your next question is, what's the difference? Or do they have both? Or do they have all three? And really kind of narrowing it down. So I hope that makes sense from a diagnostic perspective. Yeah.
Absolutely. And even in the DSM-5, within the symptoms, I mean, you almost have to be presenting those symptoms on a consistent basis. And I think they classify, is it a week or 2 weeks? I'm just going based on memory. I think you need to be presenting the symptoms consistently for, I think there's a certain duration. Right?
Yeah, exactly. That's the other thing. There's time criteria. So for personality disorders, it's usually 6 months. It's a pervasive pattern. I don't even know if it's the 6 months, but it's a pervasive pattern. It's characterological. It's ingrained in your personality. That's very different from a psychiatric disorder, which tends to be, even if they're chronic, like schizophrenia or bipolar, they tend to be more episodic. So that's the first thing. When it comes to personality disorders, people need to understand that it's what the name says. It's ingrained in your personality. It's characterological. It's who you are, which is why typically they are harder to treat. Whereas a psychiatric disorder, what they used to call axis 1 versus axis 2, is more episodic and more fluid in its presentation. So that's one way to differentiate, a psychiatric disorder from a personality disorder, let's say bipolar versus borderline.
Right. Right. And again, with anxiety and depression is also thrown around quite a bit. You can have mild forms of it, again, on the spectrum. And that's where it becomes challenging, right? So what are some things you can recommend to people that may be experiencing bouts of it, or feel like they may be suffering with the symptoms? Is it obviously it's going to an expert, but what are you looking for when you try to identify that within yourself?
So yes, of course, never self-diagnose. Self-diagnosis is pretty dangerous for multiple reasons. But if you're feeling off, if you're feeling overwhelmed, stressed out, you're seeing something different, I would say these things. When you go to present your case, so to speak, to a mental health professional, I would focus on, when was the onset? Try to think back, when did you first start feeling like this? And sometimes that's hard for us to do. Or some people say, I've always been depressed, or I don't know, I was an adolescent, or, it's hard to pinpoint. But really try and think of the date of onset. Then try and think about the frequency. So let's say you're feeling anxious. Is it more days than not? So for example, generalized anxiety disorder, which is one of the anxiety disorders, it actually has in it feeling worry and difficulty worrying more days than not. So that's kind of vague, right? But then you have to think, well, if it's a week, have I felt pretty anxious 4 out of 7? Really try to think about that. Also think about intensity. So think of everything, this is how we quantify things. This is how we get to a place where we can give a diagnosis. And there are obviously, psychologists can give objective measures and questionnaires and assessments for this purpose, which is why we do that, to kind of differentiate. Are you kind of just stressed out because of external triggers? Are you just kind of a worrier? Or do you actually have some pathology here that would warrant some kind of treatment? So onset, frequency, intensity, look for triggers, things that make it worse, things that make it better. All of those kinds of additional information is always helpful to give the provider when they're trying to narrow down a diagnosis.
Right. And the same thing could apply to depression, right? And again, the reason I cringe is because of these terms that become part of our normal language, right? Like the amount of people I hear saying, "Oh, I'm depressed," or "I get depressed doing this." It just makes me cringe, because I'm like, well, no, you're not depressed.
Yeah. Well, it drives me nuts. And I literally have this like by my side at all times. And I think that's a trend we're seeing, where young people, particularly because of social media, are over pathologizing themselves. You hear people using clinical terms all out of context. So in one respect, it's like, yay, we're battling stigma. We're talking about mental health. It's coming to the forefront, which is fantastic and it's important. But there's always going to be a flip side to something coming out in the light, which is misinformation. So I hear young kids saying, I'm trauma bonding, I'm triggered, I'm codependent, he's toxic. And I'm like, oh gosh, like, why are you pathologizing everything? I think also we need to realize that feeling off or feeling different or feeling up, high, low, those are part of the normal human experience.
Yeah.
It doesn't necessarily mean you're sick or you're bipolar or you're, and that's the danger in self-diagnosing, or just kind of reading something online and then running with it. And that's what I'm seeing a lot of. Like you mentioned, major depressive disorder has 3 specifiers now. It has mild, moderate, and severe. And so how can somebody say that, they're mildly depressed, moderately depressed, severely depressed? Well, if you go to our book, which is for use by mental health professionals, there's diagnostic criteria and specifiers for you to meet a certain, for you to meet diagnostic criteria. And I agree. I think people, I'm so depressed, or I just had a panic attack. It's like, let me tell you something. Panic attacks are so incredibly debilitating.
Yeah.
They're so horrible. As somebody who has suffered from panic attacks and used to drive herself to the emergency room on a regular basis, I can promise you that that little spike of endorphins or little worry that you had for 5 minutes was not a panic attack. So I'm with you on that. The over pathologizing, it's not good, because we're erasing the normal human experience, which is to feel differently all the time.
Yeah. Oh, 100%. And I think there's it's very subjective too, right? Like, because I may have a stressful life, I'm probably able to deal with stressors a lot better than someone who's not exposed to a lot of stress. So does that mean like I'm not capable of feeling depressed or stuff like that? I agree with you. And I guess having these conversations are important to identify that, which kind of leads me into my next question, because obviously I saw your video recently about bipolar disorder and Kanye West, and not using often these disorders or even the symptoms as an excuse for our behavior, right? And I don't want to focus on Kanye, because he's probably a whole different case study on his own,
Right.
but just not excusing our behavior and then using, saying, oh, I have this disorder, and trying to get away with it, I suppose.
Yeah, absolutely. I mean, that is one of my biggest pet peeves, especially since I've worked with criminals my whole life, seeing them, the odds of a psychiatric disorder directly causing like egregious behavior is so slim. Like you think of like Andrea Yates, who was schizophrenic and drowned her children, she was in a psychotic episode. She firmly believed, and this is through psychological testing, hours and hours of evaluation, objective measure, collateral interviews. I mean, to get to this conclusion, This woman genuinely believed that she was, from what I understand, that she was saving her children from the devil by drowning them. That is so rare, and it's so like 0.000% or whatever it is, that anybody else, you know, blaming your mental health or a psychiatric disorder for your actions it's just not how it works. You know, I'm not saying there aren't contributory factors and different, everybody's multifaceted. And like you pointed out, some people are raised in conditions where, I don't know, there's chronic poverty, or you know, I have a lot of my patients, they don't even realize they have PTSD. They've been subjected to so many shootings and so much violence and so much death that they've normalized it. And so their paranoia and their hypervigilance and their flashbacks to them are normal. And it's like, wait a second, you know, why do you not get the help you need? Because for you in your neighborhood, that was considered normal. So I digress, but there are so many factors that you have to look at before you diagnose somebody. You know, the diagnostic criteria in the DSM-5 is just one part of it. But yeah, I'm seeing a lot of people say, you know, well, I lied to you because, you know, I was anxious, or I was insecure, or I was depressed, or I was whatever. And it's like, no, things don't make you lie. You lie because you wanted to lie. That's just one example, you know? And yeah, it's not an excuse. We have to be, plus as providers, in terms of on the treatment side, not just the evaluative diagnostic side, by co-signing people's crap, we're helping to enable them. That's what people don't understand. Therapy is not fun and happy. Therapy sometimes is hard, and it's holding people accountable. And by holding patients accountable, they might hate you, they might dislike you, but how else are they supposed to get better if we still keep co-signing their stuff? Oh yeah, it's not your fault, you're bipolar. It's not your fault, you're depressed. It's not. Well, how do people get better? You know, coddling versus treatment is another one of my big pet peeves, because I see that a lot.
Yeah. No, I hear you. And I think what I've at least noticed, and based on the research I've come across, is the mental health often goes unnoticed in the low income population, and it gets compounded, and you know, it's almost a perpetual cycle in that population. Whereas, you know, higher income, it's almost like a privilege to go seek therapy and ask for help because you can afford it, right? So there's that issue as well that's not really talked about. And unfortunately, you know, just even from personal experience, seeing like therapy is not really affordable for people. And then insurance companies do a really poor job of covering it too, which is a separate issue on its own. But what do you see in the line of work, especially in you know, the prison system and all that? Like, I'm sure it's something more profound there as well.
Yeah, absolutely. I mean, for one, I made a video actually on how, because I was seeing mental health professionals getting attacked for not making treatment affordable. And it was like, we're like the frontline people. We get the attack, but it's systemic. It's insurance companies, it's capitalism. It's the fact that mental health and medical health is for profit. So by attacking the frontline people and saying like, you should make therapy more affordable, it's like, wait a second, I have to pay my rent and I have school loans and all this other stuff. But like you said, that's a whole nother topic. But so many of my inmates, I call them my inmates, but my patient inmates, you know, the first time they come in contact with mental health treatment is once they're locked up.
Yeah.
And some of these stories, it's like, if they had just gotten the help prior, they might not have gotten locked up. They might not have gotten to that point. And I'm not saying that I'm excusing their behaviors, but I'm saying, you know, there's a multitude of factors, like you said, and they compound. There's the poverty, and then the substance abuse, and then the absent parent, or the domestic abuse, or this or that, you know, nobody at school has any resources. There's no school counselor because they can't afford one, and round and round and round we go. And then they end up in jail. And it's like, you're telling me this is the first time that you're talking to a mental health professional? But of course, it's the school to prison pipeline. Like, of course you ended up here. You know, and by that time, I'm not going to say it's too late, because I firmly believe in rehabilitation and changing someone's life. But, now they have a record and now they're locked up and they're separated from their families. And then just round and round we go, this perpetuating this cycle of insanity, really.
Yeah. I mean, and to your point, there is hope in that regard too, but often, like, once you're in the system, you can't just go out into the real world and get a job and be accepted by society, because to your point, you have that record. Right. So I can appreciate how it might be tough, and to your point, it just continues, right? And I don't know what the solution is, because often what you see is where there is therapy that's affordable, often the quality isn't great, right? So
yeah. Oh, okay. So I was just having this discussion with my friend, Dr. Mack. So especially in the prisons that I've worked in, which are privatized, so literally for profit, which is what I wrote my dissertation on, but I digress again. They hire unlicensed people. I'm not saying there's anything wrong with unlicensed people. We all have to be unlicensed at one point, but unlicensed people for high risk populations is maybe not the best solution. Unlicensed, very scared, very green people with no guidance. That's the problem. These green students or young people, they might have the great intentions, but they need supervision. They need a strong leader, and the caseloads are insane. I had 15 therapists working under me when I was the clinical director of a prison here in Florida, and their caseload was like 150 inmates. It's like, how does one master's level therapist handle 150 inmates? You don't. You literally go to the cell and say, are you suicidal? Are you homicidal? No. Next. Are you suicidal? Are you homicidal? No. Next. Like, it's risk management. It's not therapy. It's not treatment. So there's that component. And then you have, I hate to admit it, but we've had medical doctors who have had their licenses revoked in the community, who are now working in prison because it's the only place they can work.
Mhm.
If your license is revoked, why are you practicing anywhere?
Yeah.
Why are inmates subhuman that they get a revoked licensed practitioner? Oh, well, it's they have it. The way they manage to do that is they call them underserved populations. And so they take these egregious practitioners who shouldn't be practicing anywhere and they assign them to inmates.
Yeah.
And so, like you said, they're getting the bottom of the barrel treatment, if you can even call it treatment, because it's really just risk management. It's really just, we don't want to get sued for suicides and homicides. That's it.
Yeah. Yeah. So, I mean, without going too far down the rabbit hole, like, what is the solution? Like, do you have any ideas? Because I mean, it is obviously an issue that's just continuing to get worse, right?
Yeah, it's continuing to get worse. And just because mental health has a lot of hoopla and recognition on social media doesn't mean the core of the problems are being addressed. So I have a friend who was a principal at a school and in an inner city. And so they had a budget for mental health. So it was like, great, this is what we do. This is what we're proposing. Start early, get a school psychologist, more than one, preferably, counselors, groups, psychoeducation for these young kids. And so he was all excited about starting that process until they told him his budget was $1,200 for 1 year for 500 students. So, like, I mean, an evaluation from a psychologist costs more than $1,200. How are you providing treatment to 500 students in an urban city school over the course of a year for $1,200? Like, what are you supposed to do with $1,200? So the first solution is allocating resources. Because if these kids in these schools did have a counselor to speak to, somebody to go to about domestic abuse, the fact that their mothers might be on drugs, or the fact that their fathers might be on drugs, or the fact that they're subjected to chronic poverty, or they're not eating, or they have seen 8 million shootouts in their neighborhood. If they have no one to talk to about that stuff, age 8, 9, 10, 11, 12, we can guess the outcome. It's setting them up for failure.
Yeah. No, I mean, it's again, you kind of alluded to it earlier, capitalism, but it's not something we can solve, unfortunately, easily, and not something, it's not talked about, unfortunately, either, right? So that's becoming a huge problem. But getting back on course, I did want no, this is good. This is good. I did want to also talk about, and we touched on it offline, but the issues around BPD and bipolar disorder and how the two get confused, because that's something I recently came across as well. And just for context, I was writing a paper on bipolar disorder, and one of the things I came across in the research, and I want to get your thoughts on it too, is how I think it's the difference between the manic episodes as well, and how people experiencing bipolar disorder respond to medication versus people with borderline personality disorder. That also differentiates it. But if you're not, if you're going in blindly and you just completely miss the mark on that, how do you even know that your client's responding appropriately, or you've kind of misdiagnosed them from that perspective?
Right. So bipolar and borderline is probably single-handedly my biggest pet peeve, and has always been, because they always get confused. And it's a little bit understandable because of the mood lability, right? The good mood, bad mood. So here's the way that I try to explain it in concise terms. So first of all, borderline personality disorder, people think BPD is just cutters, right? People who cut and people who self-injure in one way or another. And while that is one of the symptoms, that's not really the core of borderline personality disorder. The core of borderline personality disorder is this chronic fear of abandonment, whether it's real or imagined. So you have this very push-pull interpersonal style. It's pretty hard to work with borderline patients. Some people are really good at it and really enjoy it, and other people just can't do it. So they will idealize you, and then they'll rip you down. You're my favorite therapist. 2 days later, I hate you. You're the worst therapist ever. And it's there's a book called Fuck You, Don't Leave Me. Excuse my cursing, but it's about borderline personality disorder. And that's exactly what it is. This real or imagined chronic fear of abandonment, usually stemming from trauma. So this is, your Tasmanian devil kind of interpersonal person, moodiness, I love you, I hate you, I can't stand to be alone, self-injury, depression, anxiety, kind of temper tantrums, fits. That's borderline. Bipolar is completely different. Bipolar is organic. That's the first thing. Borderline is a personality disorder. So again, an ingrained characterological part of their personality. Bipolar disorder is neurological. It's organic. It's literally, there's a misfiring, neuro is not my strong suit, clearly, but it's treated with medication. And it involves manic episodes. Manic episodes are not mood swings. Manic episodes are discrete periods of 4 days to 2 weeks where this person literally does not need sleep. They can be up for 4 days and they're not tired. They engage in high risk activities. They tend to take on new tasks. They tend to have grandiose ideas. Sometimes they have psychotic symptoms. They're so manic that they start hearing voices. They're grandiose, they're impulsive. They literally are not tired. It's like somebody being on cocaine for 4 days and they not functioning. And then they typically dip into super depression, right?
Yeah.
And that's usually the high risk area for suicide, when they're dipping, because mania is enjoyable. They're euphoric. They're out there. Yeah. And then dip into depression. So I don't know if the way I just explained that makes sense, but they're very different. Very, very different. Manic episodes and hypomanic episodes, which are kind of mania on a smaller scale, are very different from a characterological person who's doing this kind of push-pull abandonment fear. But people think that bipolar is just mood swings, or borderline is just mood swings. So anybody who has mood swings, they just write. And so going to your question about medication, bipolar disorder, the first line of treatment is medication because it's neurological. So you have to address the chemicals in the brain in order to stabilize them. So you have lithium, you have Depakote, you have mood stabilizers. Whereas borderline personality disorder, the treatment of choice for that is dialectical behavior therapy, which is kind of teaching them to sit in the comfort, addressing cognitive distortions, behavioral activation, mindfulness. Two completely different treatments, you know? Those get mixed up all the time. Huge pet peeve. Huge.
Well, the other differentiation is also delusions, right? Like for bipolar disorder, people do have a lot of delusions as well. And to your point, if you by accident give someone with BPD medication, that's probably not the right approach, right? Especially if you're misdiagnosing them.
Yeah, I mean, severe borderlines tend to be on medications. They can also sometimes also be on mood stabilizers. Obviously, I'm not a psychiatrist, so I can't speak to the exact mood stabilizers and the dosage and all that kind of stuff. But typically, the mood stabilizers for borderlines are to address that kind of mood lability and the suicidal behavior, to keep them from self-harming. Whereas with bipolar patients, it's literally to address the mania and the depression. So again, yeah, mood stabilizers, you might give them to both patients, but and again, I defer to psychiatry for that, but they're very different disorders. I don't even, if you really sit down and look at the DSM or the ICD, or you really study them, you realize they don't have that much in common. But people think bipolar is, people make jokes like, what I used to hear a lot from my patients, like, yo, I used to wake up in the morning, I think I'm bipolar. And I would say, what makes you say that? And, well, I wake up in the morning and I'm in a good mood, you know what I'm saying? And then like in the afternoon, if my girlfriend doesn't write me, like then I get super angry and I go nuts. And it's like, okay, sir, that's called life. Like that's not any kind of disorder. That's low frustration tolerance. You're mad because your girlfriend didn't write you. But yeah, people make jokes like, oh, she flipped out on me, or my girlfriend went crazy, she's bipolar. And it's like, nope, that's not what that is. That's not bipolar at all.
Right. Yeah. And like we discussed at the beginning, there's a lot of symptoms you have to check off. There's a time constraint on it too. It's not simply something that and the other part to it all, as you've alluded to in your examples here, is very subjective, right? Just because someone is mistreating you or you don't like the way you're being treated doesn't mean they're probably suffering from some disorder.
Yeah, right. So that's the other everyone's a narcissist now. Have you seen that? Everyone's a narcissist. Yeah. So it's like, my boyfriend cheated on me, he's a narcissist. I was gaslighted, or I was lied to. It's like, no. Like, he's an asshole, but he's not a narcissist. Like, narcissistic personality disorder, I literally just checked this when I made a video a couple weeks ago. Community samples in the DSM research, empirical science data shows that people who meet criteria for narcissistic personality disorder in community samples was something like 1.4%.
Yeah.
It's really low to have. I mean, people can have traits of narcissism. You can have narcissistic traits. You can have a big ego. You can be self-centered. But to actually have narcissistic personality disorder, like, it's pretty rare.
Yeah.
So just again, someone doesn't mean they're a narcissist.
Well, and again, it's on a spectrum, right? And in our last episode, we did cover NPD, but we didn't talk about the spectrum side of it, where on one end, as you mentioned, someone can have a big ego and can be self-centered, and but then on the other end, they can also not represent those qualities and still have narcissistic tendencies where they're seeking sympathy or attention, and that's often not really talked about.
Totally. I think every human can be manipulative to some extent. I'm sure I've done it. I'm sure you've done it. There are times where people have lied or cheated, or they've treated somebody badly, or, they've, like you said, they've sought pity in a kind of a manipulative manner. So and that's the other thing, like pathology, like you said, is on a spectrum. I've had extremely, chronically very ill schizophrenic patients, and I've had schizophrenic patients who hear voices every now and then. I've had horribly narcissistic psychopathic patients that you're like, okay, this person need not be in society. And then you have some people that are narcissistic, but they still manage to kind of function and have relationships. And so that's, again, where people don't understand that just because they meet diagnostic criteria doesn't mean we don't still have to individualize the person. Every single patient is different, every single one. I don't think you or I have ever had a patient that's maybe similar, but that presents exactly the same. It's not the way humans work.
Yeah. Oh, 100%. And I think that's what, just from this conversation, hopefully people can realize it's so complicated, right? And even for like professionals like yourself to say that, it's not easy, and you have to look for many, many things, and every client can present themselves differently, that should be telling for people that are potentially diagnosing without any real qualifications. So that's the other thing I hope people realize.
Absolutely. And also not to be dismissive, and even the best, most objective professionals can be dismissive. I've been guilty of it. Oh, well, he's borderline, so, he goes over there. Or, well, that guy's bipolar. He just give him meds, it's more than that. People are multifaceted, multidimensional, and if even the most educated and objective or seasoned, experienced clinicians can be dismissive, then imagine what non-credentialed Joe Schmo life coach is saying about people. And I'm not, let me back up. Life coaches, they have their place, but it's dangerous when people go into territory that they're not supposed to go into. Case in point, like, I can talk about how mood stabilizers are the way to go for both borderline and bipolar, but I know better to say I'm gonna refer that right to psychiatry, because that is not my area. That is just not my area. I do not prescribe medications. So I think it's really dangerous. It's very dangerous. I mean, we can laugh at it, but it is sincerely dangerous. You know what I mean?
Well, and the reason why I laugh, and I mean, I shouldn't be, but I've seen some people post articles about how coaching and therapy can have similar outcomes, and that scares me too, because there are articles like that out there, because I did look into it, and we have to be very cautious, because there is an aspect of, again, depending on how severe your symptoms are or even your condition is, because some people just need someone to talk to, right? That's fine.
Totally.
Maybe you can get the same outcome by going to see a therapist, or especially if you're a high functioning individual, or going to see a coach. That's fine. But in most cases, if there is a disorder or a condition, then you're probably not going to get the same outcome with a coach. And that's where I think, to your point, it becomes dangerous. And
and there's a time, there are times and places for coaches. I'm not knocking that either. I think, what are your goals? What are the goals of the person? For example, I have a couple friends who work in ADHD coaching. And so and I was like, what is ADHD coaching? Like, that doesn't even make sense to me. But I read up on it, and there's a certification process and all this kind of stuff. And it's regulated, which is, really important. And it's more somebody who's going to help somebody with ADHD, with true ADHD, set reminders, make lists, tend to tasks, hold a schedule. That coaching is fantastic, because somebody with true ADHD could absolutely benefit from a coach who's literally going to motivate them and coach them into building better habits to address their ADHD. So I don't want to make a blanket statement that I don't think coaching has a time and a place and a purpose. It absolutely does. But like you said, it depends on the individual, the pathology, the treatment goals. What are we trying to accomplish here? I think, listen, the more the merrier. It's kind of like, we also have case managers. Case managers, they might only have but they might just have, a bachelor's degree, but that doesn't mean their job isn't just as important. They are managing the case. Does that mean they're evaluating, diagnosing, and treating? No, but they can hold the case together. As long as everybody understands that there's a role and a place and they stay in their lane, the more the merrier. I'm all for it. Give me a coach, give me a psychiatrist, give me a psychologist, give me a therapist, give me a couples counselor, give me all of it, but we have to know, I know when I need to refer out. Like, for example, the other day I got somebody with anorexia. I'm not well versed on eating disorders. I just know the basics from schooling, but I wouldn't want to do that patient a disservice and say, like, give me, I'll do it. No, that's not fair to the patient. Let me find you somebody who treats eating disorders and let me refer out. And I think if we all learn to do that in a more harmonious way, because at the end of the day, it's about the patient. It's about, you know what 100%. I mean?
Yeah. And I think the responsibility lies with people too, right? To be sure, like, it's good to help, but you have to be aware of, often you can make it worse, right? So being aware of that, and to your point, when there are regulations involved, it keeps things in control. And unfortunately, with the coaching business, there's no real regulations often involved. But as people, if you're listening, I think it's also your responsibility to be aware of where you're seeking help and who you're going to, and doing your due diligence, because to your point, you have to be aware of a lot of these things, especially if you want the right help.
Yeah, and as a consumer, there's nothing wrong with asking, what's your education? What's your license? Which state are you licensed in, or which country are you licensed in? What board of ethics do you follow, or what kind of certifications do you have? There's nothing wrong with asking that, even for medical providers, or if you're going to a dermatologist, do you want a board certified dermatologist? Those are all in place for a reason. And so I don't think there's anything wrong with looking at that and asking about that.
Yeah, absolutely. No, this has been a great conversation, Lena. Always, I enjoy your passion and
Thanks for that.
but I know you've shared a lot in the past, but like for listeners that do want to get a hold of you, reach out to you, what are some ways they can do that?
Yeah, and thanks for I always love talking to you, and I love watching your stuff on social media. You seem to have this like awesomely calm demeanor. It's like the opposite of me, and this very insightful stuff. And I love that you're furthering your education. Like, that's so awesome. So thank you. Let's see. My website is www.risepsychological.com. My Instagram, I have the longest Instagram handle on the planet. It's also Rise Psychological Services. I think there's some underscores in there. And I cross post on YouTube, Rise Psychological Services there as well. So there's
I've shared your info in the past, but I will as well in this in the show notes for this episode. But yeah, thank you again for coming on and having this conversation with me. I've learned a lot, and what I've also learned is I don't know a whole lot. So hopefully people can realize that too, especially if you're stepping out into unknown territory, as we have established in this episode.
Absolutely.
Thank you for tuning in to another episode. As always, please subscribe to the podcast if you enjoy the episodes, or leave a comment in the comment section. I always love hearing from you. Thank you again, and until next week.